Welcome to this podcast from the Medical Journal of Australia. It's coming up to this year's International Women's Day, and today's guest will talk about continuing gender inequality in health. In an article published today in the MJA's Insight Plus, PhD candidate Rachel Mather, who is a committee member of Women in Global Health Australia, and Associate Professor Meru Shiel, who is a chair of the organisation, state that women occupy 70% of frontline health positions and only 25% of leadership positions in global health. My first question goes to Associate Professor Shiel. Is the world on track to achieve the United Nations goal of gender equality by 2030?
Sally, thank you for that question. I guess the short answer is no. So the SDGs, or the Sustainable Goals, Development Goals, were adopted in 2015, and that was one of the key critical moments in time where there was institutional support for women's leadership and gender equality in global health. And it sort of gathered a lot of momentum, but since then, we've sort of seen some progress, but there's also plateauing of progress. There have been some great initiatives that we talk about in this article around the establishment of Women in Global Health, which we are representing the Australian chapter, Global Health 50/50, as well as the Women Leaders in Global Health Conference. So lots of initiatives, but what the data is telling us that even though women form 70% of the health workforce, frontline healthcare delivery, only 25% of senior leadership positions in global health are held by women. So a lot more work needs to be done, and we're definitely not on track to achieve the Sustainable Development Goal 5.
And Rachel, do you want to add to that?
Yeah, I think in terms of women's equality more broadly, and progress towards Sustainable Development Goal 5, it will take 134 years for women and men to reach parity in income and legal rights. And these are numbers that were, I guess, last reported in 2024, 2023. So with the current sort of global political climate, it's possible that some of these indicators will be further delayed. It will take 137 years to lift all women and girls out of poverty. So gender parity in parliaments potentially won't be achieved until 2063, while at the current rate, it will take more than 300 years to end child marriage. So there is a long way to go before we can really realise that Sustainable Development Goal of achieving gender equality for all women and girls.
And what does the data show about the proportion of women in leadership roles in global health?
Well, as Meru highlighted, women comprise more than 70% of the global health frontline workforce, but they are less than 25% of global health leadership. So that's a really well-worn statistic. I think just about any paper examining women in global health in the past 7 or 8 years has cited that. We probably need to get more current data. But I think the COVID-19 pandemic, in some ways, there were some successes. I know some successes in Australia, but in other areas, women's sort of contributions to global health were really dropped to basically be that frontline face and not have the contributions at the leadership level. And that's, across the different levels of the health sector and certainly politically as well. So another initiative that Meru mentioned was Women in Global Health 50/50, and the focus of their report last year was looking at global health boardrooms in terms of geographic equity. And it found that it would take 27 years for non-profits and 367 years for for-profit companies, organisations to achieve geographic equity when it comes to women in global health. So that's really speaking as well to representation of women across the different intersections, not just women in Australia, but women from low and middle income countries. And we don't have a lot of information on other intersecting factors for women.
And I guess maybe if I can add to that, Sally, just even, we're talking about global health leadership, but we also saw there were studies done during the COVID-19 pandemic, which looked at, what was the role and gender parity in decision-making bodies for COVID-19. And what this particular study found was that only 3.5% of the 115 identified COVID-19 decision-making and expert task forces had gender parity in their membership, with like 85.2 being majority men. So that's telling you something in a pandemic decision-making, whose voices are being heard. And I guess the challenge, and we'll talk about this more, is that I believe only 87 countries in this analysis, very rarely was the data publicly available on who comprises and who's forming these committees as well. So, it's been seen time and time again, we're seeing this pattern of that women are not in the decision-making conversations at the table, which obviously is going to, as we will talk more, has an impact on health and other aspects of the society.
And speaking to that, why are women in leadership important?
Women form 50% of the population. So from a logic perspective, it's an obvious thing as well, from a notion of equality, that if women form 50% of our population, almost 50% in most settings, then they should be representing 50% of our leadership as well. But I guess from a more even thinking scientifically and talking about it, more and more there is increasing evidence that of having women in leadership has a positive impact.
Are some women less represented than others?
Yes. So in terms of women's representation, we absolutely know that women, for example, from high income countries are more likely to have a seat at the table than women from low and middle income countries. So the Global Health 50/50 initiative publishes a report every year on, I guess, the state of women in global health and equality in global health. And last year, the theme of that was around women in different intersections, and particularly looking at the different geographies of women as they're represented in global health. So they highlighted that women from low and middle income countries are extremely underrepresented, comprising only 2% of non-profit board seats and 0.2% of for-profit board seats. So that's women from a whole suite of low and middle income countries. In contrast, men from the United States, one single country, represent 17% of non-profit board seats and 30% of for-profit seats. This is really important. A big focus of the global health agenda is health for all, achieving health for all. And we can't achieve health for all if the people who are making decisions, critical decisions around programming and access to programs come from one country and come from one kind of background. We really need to ensure that there are voices of people from these contexts and people, I guess, in their intersecting backgrounds as well. So yes, there are some people who are less represented than others, and we need to understand more about this. At the moment, we can kind of give broad strokes stats around women from particular regions or men from particular countries. But really there needs to be more understanding on, I guess, the different identities and hats that these people might wear, the different sectors of the health sectors that they represent, the different professions, the regions, languages, geographies, abilities, disabilities, educational experiences. There's a whole trove of information that would be really helpful to understand in order to inform programming that would achieve health for all.
And how does Australia fare when it comes to women in leadership roles?
Australia, obviously, there are some things that really need to be celebrated, and we've seen lots of positive in the health sector. We saw through the pandemic and currently as well, many of our chief health officers, so the leaders at the jurisdictional level, are women. And even through the pandemic, we had some very strong health and medical researchers, leading researchers lead the pandemic response, be it Professor Jodie McMahon, who led a lot of the modelling initiatives, or Professor Catherine Bennett, who was charged to lead the COVID-19 inquiry on behalf of the government, which are all very notable celebration moments. Yesterday we saw an initiative that got announced that the current government, the Albanese government, is funding $5 million research partnership to the Australian Centre for Gender Equality and Inclusion at Work, which is at the University of Sydney, to look at gender parity. So there's lots of movement in that But there are some ongoing challenges and limitations as well around the data availability, as well as trends that we have seen. So, for example, in the pandemic, the COVID-19 decision-making bodies, so the Australian National COVID-19 Coordination Commission at the start in 2020, this particular study reported that of 8 members, 2 were women. And the Australian Health Protection Principal Committee at the start, again in 2020, as per this paper, of 9, 3 were women. So there are some gaps that are ongoing as well. And Rachel can provide more insights into those data gaps as well.
Yeah. I mean, I think like Mary said, there is a lot to celebrate, but there are still a lot of opportunities to improve, and I think a lot of data opportunities. So for example, the Workplace Gender Equality Agency reports statistics on women's participation across different sectors. And, you know, they have some really great sort of data interactive pages where you can review, you know, the proportion of women as they're represented in boards or in the workforce, or they're looking at different policies at different workplaces. But having access to raw data that's collected by, you know, the agency would be super helpful for researchers, because there's a lot that isn't reported, and there's a lot of intersections that we just don't really understand. So looking, I guess, within sectors, the different trends, you know, around different trends between women and men, the different age groups that are represented, the different ethnic backgrounds, how they divide across women and men. So for example, the Workplace Gender Equality Agency reports that people of non-European and Indigenous backgrounds make up about 24% of the population, yet they occupy just 5% of high-level leadership roles. We don't know how to stratify that statistic by gender or cultural background or sector. So having access to that information would be really helpful for researchers in understanding their own sectors, but also in making really targeted recommendations. And I mean, a really kind of visible role as well is the Chief Medical Officer, which in its history since the role was, I guess, first implemented, there's only been one female Chief Medical Officer. So there's an acting CMO at the moment. It's a great opportunity for the Australian government to really lead in its example and, you know, choose a female candidate in pursuit of gender equality.
You've said that the add women and stir approach hasn't worked. What needs to happen to change this?
So the feminist approach really asks us to consider always who has power and who does not have power, who's missing from a conversation, whose experience needs to be considered, whose voice needs to be heard, whose voices are heard, whose aren't. And our current conception of a health system, we need to be asking ourselves, how is that constructed, by who, and for what benefit? Who does it marginalize? So the add women and stir approach would argue that, you know, these systems, they were developed largely by men historically, and probably because of that, because of the lack of representation of women and of people of, you know, different intersectional identities, there's a great opportunity to make these spaces. There's an opportunity to make these spaces more inclusive and more responsive to the diverse identities across our population. So add women and stir means basically we've got a program, we've got an activity, we're going to just add some gender outcomes, gender inputs on that. What we would argue is that gender needs to be mainstreamed. We need to be looking at every policy, every activity, every program, and consider the impacts on populations and how that activity might be, you know, experienced differently for different people. So from a gender mainstream, we'd be looking at how does this affect women and men differently? Who has access to resources in this policy? Who doesn't? Who benefits? Who loses? And we'd be trying to make these policies more accountable to be as beneficial for the most people as possible. So that would mainstream. You couldn't just add and stir. You'd be really looking at, you know, who is involved in the fabric of this activity. It's much harder to pull out, you know, women if they're embedded, whereas when women are just an add-on, it's easy to remove them, as we're seeing.
That's really interesting. So how should health systems be reimagined if they're going to become equitable?
Yeah, and just, I guess, picking up on how beautifully Rachel's eloquated, you know, the add women and stir approach is going to really limit and in fact set us up for failure to achieve Sustainable Development Goal 5 in the health sector. The systems are fragile. And it also goes beyond women. Gender as a whole collective lens is where we sort of need to be thinking about. And when we think about, initiatives that build women for leadership, we need to think about moving away from the deficient skill to more of a systems approach. And I guess if we were to say how we should be reimagining the health system, we want to put it down to three things. The first one being we need to reimagine who and what makes a leader. So we know that deeply held social norms shape how we perceive who can be a leader and the typical behaviors of leaders. I'm sure all the listeners have heard about, leaders should be tall or loud and assertive, and we need to move away from those norms. So data suggests that almost half of the world's population still believes that men make better leaders than women. So inclusivity is a mindset, and transformation of norms, gendered and otherwise, requires stratification. It requires significant disruption of commonly held attitudes, beliefs, and perceptions. And we need to see this change at all levels of the health systems. Leadership needs to be transformative, it needs to be inclusive, purposeful, and we need to hold people accountable as we think about who and what makes a better leader as well. And it's everyone's responsibility, not one person's responsibility, not just about the policy. It's about everyone in the health system being held to account and committing to seeing that change and thinking about a reimagined health system. The second one is really thinking about we need to reimagine who is valued. Again, gender bias underpins our current systems very deeply, and how we value women's contribution. Women's contributions are often less valued than their male counterparts. So professional hierarchies and sociocultural norms that exist in the health sector result in half of women's caregiving roles being unpaid, which leads to an estimated financial loss of about $1.5 trillion annually for women. So by valuing caregivers, our health system will also better value the populations they serve, as frontline workers are most common interface for health access. So really, again, thinking about how do we value women at the frontline level, but also the unpaid jobs that women are contributing towards. And thirdly, we need to reimagine what inclusivity means. We often don't cater for intersectionality, as we've talked about other aspects. And we know inclusivity impacts all aspects of access to care, including proximity to healthcare, affordability, and policies that make care accessible in terms of disability or language. Inclusivity means patients or clients feel accepted, welcomed, and valued in their interactions with the health services, which links to reconsidering how knowledge is valued as well. So really, it's thinking about inclusivity as a whole for different populations, from, again, thinking about the healthcare provision, but also those who are in leadership roles, what kind of population representation you have in those leadership roles as well. And I guess just to kind of say that all of this is very challenging when we don't have the data to back this or analyze or look at the impact of these. So there's an overall lack of data, specific data on gender, on intersectionality. And these pervasive data gaps essentially continue to exist. And effectively, we can't reimagine these systems. We can't promote inclusive, collaborative, purposeful, equal leadership in the absence of data, because without that, we don't know whom it affects, how it affects, who is valued, and what they're worth. To all our listeners, we invite all of them to march forward with us and take responsibility with us of achieving these goals and reimagining the health system, and not just the women alone in the workforce.
Thank you to my special guests, Associate Professor May Rushil and PhD candidate Rachel Mather. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.